we're going to do things a little bit differently tonight. We've taken all the feedback that you all have given us over the years, believe it or not. We're in our third year of being a CCO, almost done with it. And we're trying different formats. You can see if you've come to one of these before, we usually have at least one a year in each county, and we've had them in different formats and in different places, and we're really trying to have a more inviting presence and an inviting environment so that we can really hear feedback from all of you and share with you some of the things that we're working on and some of the things that we're proud of and want to share. And so today's program, as you can see on your table, is a little bit different and a little more structured at the beginning, and then we really want to leave that time at the end to answer questions and get feedback. There's the yellow cards on your table if you want to ask questions, and I will collect those and work on figuring out who best to answer them, or if we can't answer them, let you know that we'll get back to you, and we'll make sure we do that at the end. And so I just wanted to, again, thank everybody for being here. We're going to start with Kim Whitley, who is our Chief Operating Officer for the CCO, talking about our transformation plans, because this is one of the most important things we do in terms of our contract with the state, and what we're trying to do in terms of changing the way healthcare is delivered has to do with our transformation approach to transformation and transforming healthcare. And she's going to kick us off with some summaries on that. Kim?
Thank you, Kelly. All right, so get adjusted. As the CCO, we've been around. When we applied to be a CCO in 2012, the CCO contract through the state of Oregon brought some different elements into our contract to ensure that as a state we would be looking at healthcare differently. So the state implemented into our contracts the metrics, the 17 metrics on how we as a health plan would be evaluated and partially paid by the state. They implemented community health improvement plan requirements, which helped us and guided us in the development of our community advisory councils. And they also included in our contracts an addendum called the transformation plan. So the transformation plan is an actual contract element that the IHN-CCO has with the state of Oregon. The transformation plan calls for the CCO to implement 8 elements of transformation. The 8 elements include implementing alternative payment methodologies, integrating mental health and dental health services into physical health and primary care, addressing health disparities, facilitating health information technology, facilitating the introduction and implementation of traditional health workers, facilitating training and education for the community, implementing a quality improvement plan, and the development of the community health improvement plan. So those are the 8 elements of transformation. As a CCO, we decided to go about transforming healthcare in our region, Linn, Benton, and Lincoln counties, through a collective impact model. What that means is that we would come together, we would pull the stakeholders of the community together, and we would all agree on the vision that we were trying to achieve and how we would go about as a community addressing those 8 elements of transformation. So in 2012, we invited any provider in Linn, Benton, and Lincoln counties who had the ability to affect the health outcomes of our members to start coming to a meeting that we call the Delivery Systems Transformation Committee. And this committee meets every 2 weeks and has met every 2 weeks since 2012 with the standing opener of, you are invited, you can be here, you can participate if you have the ability to affect the health outcomes of any one of our members in Linn, Benton, and Lincoln counties. So it's an open meeting available to anybody who meets that criteria. So since 2012, that committee has been working on the collective vision of transforming healthcare through improving quality, improving access, and decreasing the cost of care. We decided to do that through the development and support of pilots within our Tri-County region to address the 8 elements of transformation. So at your tables, you have some information. I'm going to talk about this one first. So this one. you can see that it says how we find new ways to deliver care and improve health. So this is what the Delivery Systems Transformation Committee does. We have our providers, as I said, any provider who can affect the outcome of the health outcome of a member is invited to come. The health plan provides the operational support, and the transformation team is the committee that meets every 2 weeks. So we come together and we talk about different grant dollars that have come in through the CCO and how those can be used to transform healthcare. We talk about pilot opportunities, meaning what provider in the community has an idea on a pilot or a concept of how to do care differently that might improve health outcomes. And we have work groups for each element of transformation that help give us feedback on if we're meeting those 8 elements of transformation. On the back of this sheet, we list out our work groups, which mirror more or less the 8 elements of transformation. And then we list some pilots and some grants. So related to our pilots, this is not the entire list. So we've been doing this from 2012, and we actually have quite a pipeline of pilots. And we end our year for this transformation committee has 2 more meetings before the end of the year. And we had to extend our meetings to 2 hours to get through all the pilot proposals that are going to be coming before us in the next 2 weeks, because your community is so engaged in trying to improve your healthcare, and they've got all these fabulous ideas, and they've learned about this opportunity and are coming forward to get those in front of us so that we can see if they meet the 8 elements of transformation and then get them started. So on the back is just a few. I'll let you read through them. If you have particular questions about them, you can write them on the yellow card, and we're going to be highlighting one in a video here in a minute. But I did want to talk about how the pilot process works. So if any of you are interested, or you know of people who are interested in developing a pilot. So we have a pilot packet that we send to people if they're interested in proposing a pilot. The Delivery Systems Transformation Committee worked with the Oregon Health Authority, who provided some technical assistance to us on developing a proposal process that would be equitable and fair for everybody who was interested. So this process is included in the pilot packet that we send out to those that are interested. There are some criteria that pilots have to meet to make it through a kind of a phase where they fill out the packet, and if they've met the criteria, then it gets to go on to be proposed to the committee. But you have to meet the basic criteria of a pilot, most of which is really about those 8 elements of transformation. The packet has instructions, a budget template, an outcome template, because part of transforming care is ensuring that we're meeting our goals. So part of a requirement of these pilots is that they have outcomes that they are trying to reach and that can be measured. And then there's a scorecard that the transformation team scores each pilot against to help guide us in our decision making. So draft proposals are sent to a quality analyst that we have within the CCO, and she works with the pilot proposers to make sure that they've understood the proposal requirements and works with them to develop. Sometimes she helps with them to develop their budgets or to develop, to help guide them in what the most successful pilots have had and the language that they've used. So that when they get to the Delivery Systems Transformation Committee, that they fly through really fast and they get approved. And that actually happens more often than not. We approve most everything that comes before us because it's met all those criteria pieces by the time it gets before the committee. Once it goes through that process, then it's proposed to the Delivery Systems Transformation Committee. We usually have a conversation about it as a committee. Like I said, we rarely deny them, but we often send them back. And we usually send them back because they're not clear on an element of transformation. Maybe they're not clear on how it integrates dental with dental health with medical health. Or maybe it's not clear on the alternative payment methodology that's being implemented. Or maybe how it's going to be sustained after the pilot dollars run out isn't clear. And so oftentimes they'll run back. And I think the most we've sent a pilot back to be reviewed is 3 times, which is quite a bit. But again, if we want to transform care, then we want everybody to start thinking thinking in the same way so that we can move further faster. So once the Delivery Systems Transformation Committee approves a pilot, then it goes to the Regional Planning Council. And the Regional Planning Council reports to the board. And so their job is to decide whether these fall in line with the overall goals of the IHN-CCO. And in this, you also have this piece of paper in front of you. This piece of paper talks about the committees, the oversight committees that support the IHN-CCO, and or underlying. So health plan operations is the foundational workhorse underneath the CCO. But we have the IHN-CCO Board of Directors, the Regional Planning Council, and the Community Advisory Council. And the Delivery Systems Transformation Committee reports up to the Regional Planning Council, so they have to approve everything that we recommend as an approved pilot. So that is the pilot process for 2015, which is almost over, so this is going to change, but I wanted to give you all a sense of our priorities for 2015. In 2015, we prioritized the funding of pilots in four ways. Pilots that accelerated the spread of alternative payment methodologies were a priority for us. So if somebody had something with an alternative way of paying for care, then those rose to the top for the team to look at first. We prioritized the spread of promising practices from current pilots. That meant that if an element in a current pilot looked like it was having success and having good outcomes related to improving people's health, then we wanted to expand those quickly to get so that we could improve everybody's healthcare and everybody's healthcare experience. Another priority for 2015 was any proposal that would positively impact the metrics. So the IHN-CCO, we have those 17 metrics which the state looks at our plan to see how we're meeting those metrics, and part of our reimbursement comes from our ability to meet those. And so we decided a priority was helping the CCO to achieve those. So any pilot proposal that touched a metric would get looked at first. And then the final priority was finding gaps in care and any new ideas that were really outside the box that would offer us a different way of looking at how care was provided. So those were the top priorities for 2015. As I mentioned, we have 2 more meetings left in 2015, and then in 2016, we'll spend the first 2 meetings developing our priorities for the 2016 funding process. So with that, I wanted to share a short video with everybody about one of our pilots. This is a very exciting one. I can't remember if it's on the back here. Yeah, so on the back where it listed some of the pilots, the Universal Prenatal Screening Pilot. This video is going to give a short overview of that.
Hi, I'm Carissa Cousins, and I want to thank you for coming today to listen about the Universal Prenatal Screening Project. I'm directing the Universal Prenatal Screening Project. It's an IHN-funded grant that we received. It's kind of hard to talk about something with the word universal in it in 5 minutes, so I'm going to go off on a little bit of a different tangent. I want to talk about leprosy. So leprosy is a disease that's been around for thousands and thousands of years. Leprosy was originally thought to be caused by unsanitary conditions, a poor diet. It was thought that people who were impure would get leprosy. People tried to hide their disease. They would cover themselves up. They would hide from services. Sometimes it would be legal people that would try and come and take these people away. Sometimes it was social services that would come and try and take these people away. So these people were hiding. They were trying to evade being caught. They were often shamed and ostracized and stigmatized. They were often pulled apart from their families and placed in sanatoriums and isolated from their communities, and they were alone. So this is a disease that's been around for thousands of years, and it wasn't until the late 1800s that there was a cause for it, and it was discovered that it was Mycobacterium leprae that caused this. And it wasn't until the 1940s that there was found a cure for this. So people with substance use issues, addictions, and mental health concerns face many of the same problems that the people with leprosy used to face. And we need to change our culture from that kind of more primitive thinking of ostracizing and shaming to one of accepting and understanding. So unfortunately, like for leprosy, there is no cure, and there is no one causative agent. We need to understand that addictions and substance use disorders, depression, they aren't choices that people make. People don't choose to be depressed or to use meth or be addicted to heroin. These aren't choices. Addictions and mental health conditions are brain diseases, and we need to think of them just like we think of any other kind of medical condition. So what we're doing with the prenatal screening project is we're educating people on these illnesses and how to deal with these illnesses. We're trying to open the door to these conversations, these difficult conversations, so that people can feel comfortable talking about it. We don't want them to hide like the people with leprosy had to hide and be ashamed. We want people in our community, our medical providers, our nurses, our social workers to feel comfortable talking about substance use disorders, mental health, domestic violence. We want people to ask these tough questions and listen to the answers and support these people with non-judgment and empathy. So in short, through the Universal Prenatal Screening Project, what we're doing is we're using an evidence-based standardized questionnaire called the 5 Ps, and it asks questions about substance use, mental health concerns, domestic violence, and tobacco use. We're working then with a woman's own desire to make those changes in her life. We know that we can't tell someone to just stop using or to just be happy. We know that we can't direct people how to change these behaviors. We need to work with a woman's own motivation to make these changes. So we're using something called a brief intervention and some motivational interviewing skills. So we're taking that shaming and blaming away from issues like substance use and mental health concerns. And we're working with the women to find their own motivation to make these changes. And if a woman is willing to make that change and she's ready to make that change, then we're connecting her with those services. And we're doing that through warm handoffs through the appropriate providers. So really what we want through this project is for people in our community, our healthcare providers, to be able to say to a woman, hey, I understand it's tough. I'm here for you, and we can get through this together. Thank you.
So I think that's just a brief example, obviously very brief, of all the good work. And again, all the work is really happening within the community by so many people in the community. And our goal is to try and share some of those pieces with you in each of these meetings so that we get the word out about all the work that's happening. We're going to move into hearing from some of our board of directors, and we have a number of people from our board of directors here. We have Commissioner Bill Hall, who is on the board of directors. We have Doug Boyson, who's Executive Vice President with Samaritan Health Services, who's on the board. We have Dr. Larry Eby, who is the Chair of our Community Advisory Council. And I don't think we have any other board members here. Did I miss anybody? Okay. So we've asked a few of them to come up and give a quick summary of sort of what's working and what's not working, what they see their role in the board and how the CCO is working from their perspective, whether it be the integrated delivery system perspective, the county perspective, the community perspective. And then we're going to tie it all together with Dr. Ewan Chinna, who is our Chief Medical Officer, to give us a summary with more of a focus on quality and clinical indicators and outcomes. And then we'll move into our question and answer period and our questions we already have. So first, we are asking Dr. Eby to come up, who is the chair of our Community Advisory Council, and he has been the chair for 3 years and also on the board of directors. So.
Well, I like this place for several reasons. One is I didn't have to sit up here at a table for the whole hour and a half and have you look at me and all my weird appearances and so forth. So you just had me for a few minutes. It was the effort of the people that plan these programs to make them more interesting, and so they want us to make our presentations exciting. I don't know. It's a bit of a task. First of all, because guess what I'm supposed to talk about? What are the 3 most important responsibilities of the CAC? Now, isn't that exciting? There are only 3, and they're mandated by the state, and they're in our charter, and so I feel compelled to read them. The responsibilities of the CAC include, but are not limited to, identifying and advocating for preventative care practices to be utilized by the CAC. Now, like a good preacher, I have a text and I'll expand on it. This is really a very important thing, and it's very integral to our community health improvement plan, where in fact, it is one of the main goals of the transformational approach to medical care, and that is to have preventative care practices and not just therapeutic care practices. And so through our community health improvement plan, and I'll talk a little bit more about that later, how that came about, we are doing that. We have done it, we continue to do it through various things that we do. And in doing that, B, the second thing is overseeing a community health assessment and adopting a community health improvement plan to serve as a strategic population health and healthcare system service plan for the community served by the IHN-CCO. When I had my very first meeting with Kelly about 3 years ago, she gave me this paper. She said, "That's what you're supposed to do," and I thought, okay. And with the help of Rebecca Fowler, who is back there, our coordinator, we did it. And now we are in the process of looking at those and trying to figure out how we make them more meaningful. And the last thing is publishing a report on the progress of the Community Health Improvement Plan. That's C. That's pretty boring. So, what is the most exciting thing that the CAC is involved in today? There aren't exactly a lot of things to choose from, as the very nature of our responsibilities mean that we spend most of our time and energies on the responsibilities mentioned above. It would not be unfair to suggest that the most exciting thing that the CAC is involved in is to be part of transforming healthcare in our Tri-County area. A multitude of agencies and persons are involved in this. Each plays a unique role. As involves the Advisory Council, beginning at the county committees through the work groups and frequent other meetings, ideas are generated that are tested and filtered through the assessment and improvement plan and filtered and assessment and often surface for the exciting pilot projects, which you just heard about. Working together and encouraging each other strength is a journey and cooperative generation of ideas and projects that is something we could all wish for, especially something as meaningful and beneficial as the projects coordinated by the IHN-CCO. So each county has a committee that meets once or twice a month, and they were the energy people, they were the resource people And with Rebecca's help, did the work of doing, first of all, the community health assessment plan to determine what are the needs of our Tri-County area, and then putting together an improvement plan to try and carry these out. And I don't know if you mentioned this or not, I wasn't paying attention, but every pilot has to pass muster with our improvement plan. And most of them, there are several things that they fit into. Sometimes it's just one if it's a particular thing, but they all must pass muster with our improvement plan. And I don't know how many things really came out of it that the people that projected pilots got their ideas from, whether they got it from our chip or not. I'm not sure about that. I'd like to think that they did, but I can't prove that. So it's, as I said, I think the most exciting thing is to be involved in transforming healthcare in a Tri-County area. And if you are willing to spend hours a month, sometimes hours a week, with a lot of really nice people that are all interested in in this sort of thing at the county level, you might get on the council, and you might even get sometime elected chair of the council, but not for 3 years, because today we just elected a new president, new chair at our last CAC meeting, who was installed today by the board, and it is none other than your own Ellen Franklin. Would you? So, after my boring chairmanship, although it wasn't always boring for me, Ellen, I'm sure, will bring excitement and new ideas, and I'm so happy to turn things over to her, but not this evening yet. Any questions? Thank you. Oh, one more thing. Who all here is on a local committee or on the CAC? Raise your hand up high. Okay, look around. And Chandler Davis is here, and he used to be on, so. And maybe someone else, too. Anyone else that was on and isn't? Thank you.
Excellent. And just a reminder, the smaller white cards, if you're interested in being involved, please let us know, and we'll make sure we connect you up with the local committee or the regional committee or any other committee that would be of interest to you, so we'll do that. And now we're going to ask Commissioner Hall to come up and talk about how things are going from the county perspective.
Thanks, Kelly. And the title of my remarks, but don't panic, I'm not giving you a long speech. All my notes are on one page. But my title is The Island's Touch, and I will explain when we finish what that is all about. Now, I think most of you know, but just in case anybody was wondering, I am not a healthcare professional. I'm a county commissioner, which means essentially you're jack of all trades and master of none. But I do spend a lot of time with healthcare professionals, and it has been a fascinating journey and a fascinating education these past few years. A lot of people really still, I find, don't know much about what this whole CCO thing is all about. They know it has something to do with healthcare, and even if they understand that it involves the 30% roughly of our population here in Lincoln County who are Oregon Health Plan members, they think, okay, it affects those folks, but if I'm in the 70% who are not OHP, it doesn't affect us, but it does. This is a fundamental transformation in the entire healthcare system based on something called the triple aim: better health, better care at lower costs. Sounds easy, right? No. The Regional Planning Council has been together for 5 years. This was a group of public and private partners who came together. Lincoln, Benton, Lynn counties, Samaritan Health Systems, the Samaritan Health Plans, Cascades West COG, which operates senior and disability services in our region, as well as private providers. And we started talking even before the Oregon legislature had passed the legislation telling us what exactly a CCO would be and how it was supposed to work, we sat down together and started talking, getting to know each other better. Not that we hadn't worked together, but we realized that this was going to be working together in a whole new way. And that's where the island story comes in. Marty Cahill, who used to be in charge up at Samaritan North Lincoln until Dr. Mullins said, "Go east, young man," and he moved over to Lebanon. But when I was kind of having a farewell conversation with Marty, and we were talking about this, and he came up with what I thought was really kind of a great metaphor for what this process is all about. He said, "It used to be like we were on our separate islands, drifting through the seas, waving hello to each other, but our islands weren't touching. Now they're starting to touch. Now we are really building bridges that link the islands together." And so the Planning Council was created, it worked together. We essentially established the structure of what the CCO would look like. It came into being August of 2012. And it has been growing steadily, even phenomenally. On January 1st of this year, we went from 8,140, we went to 10,949 members in Lincoln County versus 8,140 in 2013. As of November 1st of this year, we're all the way up to 12,863 CCO members in Lincoln County. So this is directly touching a lot of lives and indirectly touching all the rest of us. You heard Dr. Eby talking about that jam-packed, exciting Community Advisory Committee. Well, that structure came from the Regional Planning Council. And I think both the Regional Planning Council and the Community Advisory Committee have really provided a strong provider voice and a strong consumer member representation and voice. We are successfully meeting all the requirements that the state has laid out for CCOs, including developing a community health improvement plan for the region. So the islands touch. We're not quite to, if anybody knows history, the great mythical single continent of Pangea, when all the land masses came together, but we're headed in that direction, and it's an exciting thing to play a small part in. Thank you.
All right, wonderful, thank you. And now we have Doug Boyson, who is Executive Vice President, Chief Administrative Officer with Samaritan Health Services, going to give the private sector provider side perspective on how things are going. And you have to follow the island story, so.
So Dr. Eby said that this was supposed to be entertaining. I didn't get that memo, so. Actually, I must admit, I'm kind of a last-minute fill-in. Dr. Mullins was supposed to be here tonight, and he regrets that he can't be here, but he's undergoing oral surgery right now, so I'm standing in tonight. And I was asked to talk about kind of how I view the primary responsibilities of the board. And before I get into those specifics, I'll talk generally, just kind of my experience with being on the board of the CCO. I think it's a great group, and I'm honored to be part of that group. I think it's a very collaborative group. I think it's a good example of shared governance where we have independent community members, independent practitioners. We have folks from Samaritan. We got folks from other systems. We have folks from local government as well. Each of them bringing their own perspective to the table. I think each bringing the expertise that helps us come up with a better solution as a whole. So it's been great being part of that. I think the other thing about the board is what I've seen and what my experience is, they're all very sensitive to the needs of the communities and very in touch with the needs of the communities. So I think that brings a lot of value to the CCO. Now, specifically kind of what I view the role, the primary role, you'll all see on your table, there's a diagram, and I think it says the board directs the goals and policies, and I think that's absolutely true. I think to be a little bit more specific around that, I look at, as a board member, the triple aim is what we're all shooting for, right? And Commissioner Hall mentioned that better health, better care, lower costs. Sounds almost impossible, but I think through innovation and coordination, those are some of the things that we can start accomplishing. But it's not just the triple aim, it's the triple aim laid in context with the needs of our communities and trying to figure out what are the most important needs. And as a board member, we really rely on stakeholders, we rely on these types of meetings, we rely on all the committees that are involved with the community health assessment and taking that feedback up to the board so we can really fine tune and prioritize what are the needs and then how do we accomplish that. The other thing I'd note, I think a big thing that we're always focused on is, the overall vision of the CCO. And as we hear different ideas, different innovation projects and things Kim was mentioning, how do we prioritize all those good ideas? Because there are a lot of good ideas out there. There are only so many resources and we only have so many people, human power, to put these things together. And that really is the job of the board with administration to figure out, okay, what is most important at this point in time, and then what things do we stagger over time. And then lastly, I think we have to look at it to make sure that the CCO is sustainable in the long term. And that can be somewhat kind of the more boring part, but a very important part, that we make sure that financially we're not upside down, that the CCO is making good, prudent business decisions. Today we had a board meeting and we passed the budget for next year, and that's a very important thing the organization has to follow. And then I guess lastly, I'd just say, as part of sustainability is making sure that the CCO is complying with the law, that we have a good compliance program, and that it's acting with integrity, because if it wasn't, it wouldn't be very sustainable. So those are the things that we look at. As someone that's been in healthcare for a while, what I find most exciting, though, being part of the process, is just the islands coming together, the big land masses I think you referred to, because there's a lot of land mass out there. And as I sit around the table with people from the county and the providers, weren't always talking. A lot of people doing really good things. And I remember when we were first starting up the CCO, and Kim was putting together an inventory of all the great nonprofits and governmental agencies that were doing things out there that were part of that care continuum, all doing great things, but none of us were really talking. And we're finally talking. And I think, that's how we're going to get to the triple aim. It's through that. So, thank you.
All right, and Dr. Yuan Chin is going to come up and talk a little bit around some of the quality, specific clinical pieces, and then we'll start talking and answering some questions.
So good evening. So I'm a family physician by training, and people went into medicine, and specifically primary care, went into the profession because we really cared deeply for the people that we treat, the people in front of us. And so through today's discussion about some of the quality initiatives that we've been doing, I wanted to highlight some of that deep caring. You already heard about Dr. Cousins talking about the Universal Prenatal Screening Program. And this emanated as well from this deep caring for pregnant women and the children that are going to be born by these pregnant women. And there's also a similar project that is steeped in evidence and quality that I wanted to discuss with you tonight. And it really comes from this deep cause of caring for the public and doing what's right. When we look at clinical medicine, we look at what evidence is there to help support what we're doing. An example that I like to use is we use antibiotics to treat bacterial strep throat infections. But we know that we do not use antibiotics to treat viral sore throat infections. And we do that because there's clear evidence. One of the things that we're now embarking upon, and that we need to do education of the community, education of the public, or our patients, and education of prescribers, the physicians, is the evidence that is very clear now about chronic long-term use of narcotic or opioid prescriptions for pain that is considered non-cancer. Years ago, many physicians thought we were doing the right thing by continuing to prescribe narcotic medications for long-term chronic pain conditions. Now we know the evidence has shown us that even though we thought we were doing the right thing, there's actually more harm associated with long-term prescription opioids for chronic non-cancer pain. And we find that people are actually not functioning as well as we always intended. So the state of Oregon, along with the Center for Disease Control, which is a national body looking at evidence, looking at health outcomes, and our CCO, along with all the other CCOs, are going to be embarking on initiatives to do education about what conditions should have chronic narcotic prescriptions associated with them and which conditions should not. And this is never meant to be a discussion of what is painful, what is not painful, because each of us as human beings have our own pain receptors. And we all view pain differently. And we can never say to a patient that has been receiving pain medications that they don't have pain, that the pain is in their head. That is not true. And that's not what this discussion is about. But it is talking about the risks associated with long-term opioids for pain and what else we can do to try to get people functioning and moving beyond their pain with the other things that currently haven't always been utilized by practicing physicians and by the healthcare system. So we're going to be going through a wonderful transition over the next year in giving more services and more resources to get better pain control without our reliance on long-term opioids. I wanted to share, just in closing, just a few facts for you, and this is not meant to be alarmist, but the facts are legitimate. The facts are there from the Center of Disease Control. The facts are on the Oregon Health Authority website. And the facts are that Oregon has one of the highest rates of prescription opioid misuse in the whole nation. And in Oregon, more deaths occur from opioid prescriptions unintentionally than any other type of drug, and that includes alcohol, methamphetamine, heroin, and cocaine. And an average of 3 Oregonians unfortunately die every week from prescription opioid overdose. Many more develop opioid use disorders, and so there's many partners across the whole state of Oregon that are working together to try to reduce this epidemic. One other statistic I'll share with you is that even though the United States has less than 5% of the whole world's population, we in the United States consume 80% of the world's supply of painkillers. But yet we do not have 80% more nerve endings in our body in the United States than other citizens on the globe. So there's a lot of work we can do, but we have to do this with compassion. If we reflect on Dr. Cousins' talk again, we cannot revert back to the times of leprosy. We cannot vilify people that have been using pain medications. We have to work with them, look at other appropriate alternatives, and this will be a true partnership. But I'm bringing this up today because of now the evidence and the clinical studies that have pointed us in this direction. So thank you.
All right, so I think we've just shared with you sort of the whole spectrum of all of the areas that we touch and that we focus on, from very specific things to global things to fiduciary responsibilities. And so we just wanted to give you a sense of all the various pieces that your CCO is involved in and that we take seriously. And so I hope that gave you a bit of a perspective there. So I have a bunch of questions here I'll start to answer. I wanted to see if there was anybody in the audience who had any additional questions, or if you want me to just start with these. And I'll probably reach out to some people in the audience to help me answer some of these questions, because some of them I cannot answer all of them. And if we can't answer them, we will certainly work on getting an answer. And if you've put your name on here, we'll be able to follow up with you. So I just want to give a chance. Was there anybody in the audience who had a burning question to ask right now, or I'll start with the questions? Not to put anybody on the spot. Okay. So So right in line with one of our discussions we just had, Chandler asked a question around alcohol and drug and what's happening from addressing that issue, whether it's in Lincoln County or Lynn or Benton County. And I will say that certainly that is an area that came out loud and clear in the Community Health Improvement Plan as a need in the community. It's something that we hear feedback within various elements of community feedback that we get around the need for additional services related to alcohol and drug detox. And I can say that I know that Samaritan Health Services on the provider side has a task force that's looking at what services are currently available in each county, what is needed in terms of a program and how it would look, and what resources are available now or what resources could be looked at in the future. And so that is something that is being evaluated, especially as we move into the new year. And so Chandler, that's a little bit of an update. It's not a final answer, but it's certainly recognized that it's an opportunity that everybody's involved in. And I know Samaritan Health Services is also working with other partners to figure out what's available and what the options are. So I would expect to see more coming in the new year around some opportunities and some options.
So are you talking about a regional IHN task force?
So it's not...
Here as well.
Okay, it's not IHN specific because we're being really cautious, right? Because it's broader than that, but it's Samaritan Health Services on the provider side is really taking the lead as it looks at the service area it serves, which is the same service area as we serve. So it's all 3 counties and what is available and how can we do something. So they're taking it very seriously, and I'm on that task force, so certainly bringing that IHN perspective, and so we'll definitely share when we get to a place where there's some concrete information to share, but it is being looked at very closely. Okay, as I keep bumping into that. There's one around transparency and the fact that the board meetings are not a public meeting. So the legislation did not mandate that the CCO board meetings statewide are a public meeting. We have had this discussion. We've had this discussion in the board meeting. We've had this discussion at many of these public meetings around that. The IHN-CCO board meetings are not a public meeting, but we do work very hard to make sure that people have input at the Community Advisory Committee, which meets every other month, or at the local community advisory committees, which meet much more often than that. At these types of meetings, at the CAC meetings, we do give a utilization graph update every time in terms of where the dollars are being spent and how they're being spent. I don't have that with me, but so we do try to get that information out there and make sure that it's available and get the feedback from the community. But that is a decision that was made in terms of how we would make sure we got that feedback, and it wasn't that the board meetings were public. Okay. Track phones. Can IHN-CCO start providing track phones for OHP clients? So this is a great one. Where's Christy? So Christy works with us in our communications, and we've really looked at this and are evaluating all the options around outreach and being able to reach our members, and as Kim often says, lay the sidewalks where they walk. So how do we know where they are and how can we find them? And so I don't have an answer for that, but that is something that we are always looking at and determining does it make sense and how would we make it work and how would you get it out there and what would the use be? And I know there's some national programs around how successful that is. We have not moved in that direction yet, but I'll make sure we take that back for a discussion. Did that answer your question, Gary? Okay. Another question was around utilizing self-help evidence-based services such as the Stanford Living Well with Chronic Conditions. And I know that we have supported this in the past, looking at Dr. Yuan-Chena, and I know we are supportive of it in the past, supportive of it now as well. So I would say that absolutely, and that's something that we're supportive of and would encourage, if that meets a need for a member, would encourage them to be part of that, if you're familiar with that program. This is a great one. It says, what kinds of idea sharing exists between the 13 CCOs in the state? And there's actually 16 CCOs in the state, and there's a number of ways that the sharing happens. So Rebecca Fowler, who Dr. Eby announced, introduced as our Community Advisory Council coordinator. There's all of the coordinators from all of the community advisory councils for all 16 CCOs have a regular meeting that they talk about how things are going, what they've learned, what are things that work, what are things that didn't work, how do we do outreach. So they do a lot of sharing of best practices there. The 16 CCOs meet with the state regularly on a number of different topics, whether it be around quality, around data, around pharmacy, the CEOs. We all meet once a month with the state as well. So there's a lot of information sharing. I think the interesting thing about this question is that each of the CCOs, one of the value statements of the CCO legislation was that all healthcare is local, and so they didn't give a roadmap of what it should look like. And Commissioner Hall has often talked about this at the board meetings, where we don't really have we were given an outcome to reach towards, but no specific way on how to get there. And that was actually on purpose, because each community is different and the state wanted to make sure we had the opportunity to do that. So we do share a lot, and then we also learn from each other, but we also make sure we keep it local. So this is a question about how things are going at Lincoln County Mental Health, and I might have to defer to Cheryl just on how things are going at Lincoln County Mental Health. Could you give Cheryl Connell a microphone, please? Can you hear me? Nope.
Hello?
Okay, you might have to come up with me.
I have a pretty loud voice.
Okay. Or you can come up here, whatever you prefer.
So what is...
It's just how are things going at Lincoln County Mental Health?
Okay, that's kind of a pretty broad topic. So I can tell you, Lincoln County Mental Health is working really hard to ensure that we have the services that our members need in order to get healthy, stay independent. We recently moved our adult behavioral health services from our South Beach Clinic site into our site located in Newport on Lee Street. We have a really warm, inviting kind of atmosphere there, and we're really excited about our ability to not only be closer in town where our clients and families can more readily and easily access services, because we didn't want barriers of transportation for people to be able to come to get services. But we also have now the ability in our new facility to do a wider variety of services, including more groups. We had constraints at the other site that really prohibited us from being able to do what we wanted to do. So we're very excited and are very optimistic about our ability to meet the need for our Oregon health members. So we're on a hiring spree. We're getting new clinicians in. We have some very, very interesting and motivated clinicians that are coming on board. So again, as we bring more and more individuals who can actually see clients in, we're really excited about the good work that's going to be happening. The other thing that we're looking and doing more of is doing more communication and integration of our behavioral health services and our primary care services. We're putting a lot of effort to be able to have a more holistic approach. And that isn't limited just to the individuals that we're serving in Lincoln County behavioral health and primary care. We're looking to do more branching out into the other primary care providers in the community as well. So I'm really looking forward to the coming year for our Lincoln County behavioral health services. And I'm really glad that somebody asked the question so I could come up here and say that.
Great, thank you. And so the final question I have is around dental services. And Lincoln County has a dental crisis, 6 months waiting to see a dentist for the first time in Newport, and 3 months to get treatment. Is Samaritan getting more dental providers? So first of all, I guess I would clarify that Samaritan Health Services, the provider side, doesn't employ or manage any dentists. IHN-CCO, we contract with 4 dental plans to provide dental services. That's actually part of the state rules in terms of how dental is delivered. So this is great feedback for us. We just had all 4 of those dental plans come to our regional planning committee last week and share some of the projects and what they're working on. And I would say that the integration of dental is probably at least a year, in my mind, a year behind the integration with behavioral health and mental health. So it's coming. It hasn't come as quickly, but I think, we know access is an issue, and we'll continue to work with our dental providers to work on making sure that access is available. But the feedback is always appreciated, and we'll make sure we share that with those groups. So unfortunately, I can't answer specifically about adding new clinics, but I do know that they know that it's an issue, and I'll make sure we take it back to them as well. So that was my list of questions. Are there other questions? Are there any other comments anybody would like to share, or perspectives on how things are going? Yeah, Chandler.
I had a second question on my card.
Did I miss it?
Press release about a series of meetings on transportation and health services. Huge issue, of course, in Lincoln County. The greatest distance, the greatest internal and external transportation issues. However, both of the meetings were in Corvallis, and none were in Lincoln County. In fact, Lincoln County wasn't even mentioned. Why is that?
I will defer to Kim because I do not know that answer.
Those meetings aren't sponsored by the CCO. So those meetings are sponsored by the Council of Governments, and we can find out why Lincoln County wasn't included. Well, not like you, because Lincoln County apparently wasn't included, but we were interviewed as part of their analysis of the issues. So, and then there's some meetings next week, December 8th and 9th. There's follow-up meetings that we've been invited to where we plan to go and learn more. We will certainly, as we do in all things, advocate for a tri-county approach. So we will definitely bring up, if Lincoln County wasn't included, we will bring it up that we would appreciate that they are included. So good point, thank you.
Sorry about that. I didn't mean to miss your other question, Chandler. Oh, there's another one.
Just a quick comment. OHP clients do have the right to transportation for appointments inside the county, outside the county.
Yeah, yes, there's what's called a non-emergent medical transportation benefit, and it's run by the Council of Governments, but it's available to all OHP members to get to appointments. That is true.
Actually, for those that are interested, we have a flyer back here in the back, and there's a magnet, has information, has the phone number.
For transportation, so if you can't hear, there's a flyer in the back with a magnet if you're interested in finding out more about transportation.
I was just going to say a little bit more. I wanted to maybe clarify or speak to Chandler's point on transportation. The IHN-CCO covers transportation for medical, mental health, dental, health-related appointments. Currently, we are not provided dollars to cover transportation for social determinants of health that might result in a healthcare outcome of our members. So, for instance, if you live in a food desert and you can't get to quality, nutritious food, our current benefit doesn't cover the cost of helping you get there. And that's part of what I think the COG is looking at, is how does the intersection of transportation and health, how is the structural development of transportation within a community have an effect on the health of that community? And it's looking at that intersection and from a social determinants broader than just the physical health, mental health, dental health perspective.
I think that is exciting news. That you're looking at that broader, scope of the issue. But it seems like at this time in this county, there's still an issue with even having enough drivers to help people get to just the medical appointments. I know a lot of the clients that I work with are running into issues of not being able to make those appointments, having drivers not able to show up at the appointment time because they are so backed up themselves.
So we'll take that back as well. Thank you.
I do have another one, quick one, since I've got this mic.
Go for it.
So I'm wondering about where on the radar with the CCO is the concept of trauma-informed care. Is that something that is on the radar and promoted for the various providers?
So it is on the radar and discussed, and I will defer to Dr. Iwanchina to answer that.
So thank you for bringing that up, because it's actually an extremely important part of the healthcare delivery system. And we've actually put on some educationals as part of a grant process for trauma-informed care, for trying to train more people to be aware of how trauma affects people's lives and not re-traumatize them while they're going through different social service agencies, through the healthcare system. And it was very enlightening for me to hear from our medical students at the Lebanon school, where they came up to the IHN-CCO and said, we really are doing a lot with teaching our medical students at the very beginning about trauma-informed care and ACEs, adverse childhood experiences. And so that was heartwarming to me, because from a medical perspective, I didn't know this when I was going through my medical school training. And having young doctors that are learning this at the very beginning of their medical careers will only help the healthcare system and avoid any re-traumatization of people that have had trauma. For those that aren't aware of adverse childhood experiences, there was a scale that was done many, many years ago by Kaiser. And what Kaiser did is they looked at their entire workforce and had them evaluate their different chronic diseases. And in this closed evaluation was also the eminence of a lot of trauma that people had had in their childhood. And they really weren't putting together this cause and effect of cause of trauma in childhood and how it can make your chronic diseases actually worse in later years. There's now some emerging science that states that if a pregnant woman has a lot of trauma while she's pregnant with that baby, that they've been watching these kids growing up, and their risk of having more chronic diseases is actually higher than women that will not have trauma or not have trauma while they're in a pregnant state. So it's a really, really important part of everybody that interacts in the healthcare system to really truly be aware of. So I'm so glad you brought it up, because the more that we talk about it, the more we decrease any stigmatization of trauma, and it makes us open to hearing what our patient stories are.
Are there any other questions? Feedback? Okay, well, thank you very much for coming. We really appreciate it. We hope you have got some food. If you want to take a sandwich to go. And again, thank you. Oh, Gary.
Could we just have a show of hands of how many attendees at this meeting are actually OHP members? Current OHP members.
Current, is anybody here a current OHP member? Thank you. Oh, thank you. Thank you. Oh, thank you. Thank you. Thank you for sharing that.
We're doing some filming in the back.
Oh, I'm sorry. I'm like, what? Okay, so we're trying to make sure we get all the feedback we can. And if you're interested in being on film, and you do know we post these videos of these meetings on our website, so that if people aren't able to make them, they can see them. And then we do one of these in each county every year, so that if you want to see what happened in Benton County or Lynn County, you can go on there and watch that. But we're trying to get feedback from people who've come to the meeting on what's working within the OHP, or how the meeting is working, or just any feedback you'd like to give, and you would be willing to put that on camera. Go right outside the door here, and we would be happy to have you as part of our video presence. So thank you. Oh, yes.
Just wanted to be part of the OHP plan. I wanted to thank everybody who's working really hard and make my kids grow
healthy and be part of the community. And thank you everybody for doing such a great job. Your information is amazing, and it makes me think, it makes me more calm that you guys are working to get better.
Thank you for sharing that. That's why we're here.